dear colleagues, I'm Dr. H.B. Chandalia. I will be speaking on a very interesting topic at the RSSDI, and I would invite you to attend this talk, which is of great clinical importance. We all have to use insulin therapy in our difficult patients, especially with long-standing diabetes and complications of diabetes, and those who are rapidly losing weight and are catabolic. So when you use that, your main fear is producing hypoglycemia. And when you use insulin in an intensified fashion, the incidence of hypoglycemia may be 3 times that of routine. So you have to use it very effectively without producing much hypoglycemia. How do you do that? So I'll be discussing strategy how you do that. And some of the strategies are that always use multiple doses of insulin. And the best plan, of course, is basal and bolus plan, where 4 shots a day will be used. As soon as you attempt to do the same job with 2 doses instead of 4 doses, you come into great difficulty of hypo and hyperglycemia during certain part of the day. So more frequent doses are best. And remember, patients accept these very well nowadays because of the modern pens and almost virtually pain-free needles. Second, of course, approach is very important is that type 2 diabetics, when you use insulin therapy, you must sensitize them to insulin. That reduces the dose considerably, and when you further divide up the dose, the incidence of hypoglycemia becomes really low, and patients accept this therapy very, very cheerfully. So what you have to do really is use metformin or pioglitazone, and for that matter, sulfonylurea in small amounts, very carefully though, glinides even, DPP-4 inhibitors, SGLT2 inhibitors, many of them. But metformin, the primary agent for sensitization purposes, but often DPP-4 inhibitor and SGLT2 inhibitor also will be used in modern time to reduce the dose, and thereby you see you end up with very small 3 doses of boluses, and basal also a small dose, and that really reduces the hypoglycemia. Also, you like to use good insulins, although for economical considerations, the basic treatment where bolus can be human regular insulin, and the basal can be really glargine, but there are much better insulins available as well, which are very rapid acting insulins for bolus purposes. And of course, very good basals are available, which give you very steady concentration for 24 hours without much day-to-day and variation or even during the day variations. So I think you use good type of insulin. And remember, at times you will have to revise your glycemic goal as well, because you are attempting to lower the A1C to like 6.5, you may produce a lot of hypoglycemia. So in a difficult patient, especially type 1, you will have to revise your glycemic goals. And instead of attempting 6.5 or 7, you should be happy with the 7.5 or 8 glycemic goal in a long-standing diabetic, for example, type 2 with a lot of complications, cardiovascular, renal, retinal complications. You like to do that and revise your glycemic goal. So some of these strategies and of course how to plan your doses where you cause less hypoglycemia will be discussed in talk. So I again urge you all to attend in large numbers. Thank you very much.